Actually, maybe Brenda, can you be in charge? Because Helen's up on the panel. I have my phone, so I'll watch the time, but in case we're going over, just... Okay, perfect. All right, so can I have Zelia, Helen, and Mary Beth come on up? So, and Zelia's slides up, please. She's going to start. So before we went into the... this is not intended to be a research meeting, but we wanted to talk a little bit about some new and exciting research in retinoblastoma, and also about the ways in which your child and you as parents could participate in research that was touched on once already today, and also a thank you, a short discussion of what we have already done in retinoblastoma and how that research has really changed the way that we treated children 30 years ago versus now. Okay, so you're up.
Well, first of all, I just want to repeat what everybody already said. All the physicians that have been here, this is really an eye-opening experience for all of us. And I think all of you, patients, survivors, families, you are making us better physicians. And so we thank you. We feel very humbled to be here and to be part of this. Thank you very much. So my name is Zelia Correa. I'm a professor of ophthalmology in Cincinnati, and I love taking care of patients with eye tumors. When I went into ophthalmology, I thought I was going to be just, doing cataract surgeries and everything. And then oncology happened in my life. And I felt like, I found a deeper purpose for me. And so that's what I do these days, and I love take care of children with retinoblastoma. I was sharing with the mom previously. I said the problem that I have is between my EUAs, I can't let go of the families. And my nurse is tapping my shoulder and saying, "Doctor, the next EUA is up." And I'm like, just 2 more minutes, I'll be right there. But anyway, this is good because it's kind of a soul-feeding thing. And it makes us better people, makes you feel, like, I've done something really cool today. Nevertheless, I'm here to talk to you about types of research we want to share with you, and we want to educate you a little bit on our part and things that you can learn and you can be better at understanding and even discussing and supporting as well, because I think that you guys should be the driving force for a bunch of different studies that should happen. So first of all, I want to describe and illustrate the various types of research and how they can apply to retinoblastoma. Then I want to explain a little bit of the terminology. You hear us doctors, we have our own little jargon. And boy, oh boy, it's hard for us to get out of that. Sometimes, some of my patients say to me, Dr. Correa, I really appreciate when you speak English to me. And I said, I got to remember that. Although I'm not a Native American, so, or a U.S. person, so I was born in South America. But anyway, and discuss how the treatment of retinoblastoma has evolved. And I do urge you to really look at the graphs I'm going to share with you. And then I want to inform your families, you all, about things that are happening with the Children's Oncology Group and how they are set up and how you can get a lot of information. I think probably a lot of you already know, but how you can get a lot of information from their studies and even be involved. Okay, so types of research. We're starting with meta-analysis and systematic reviews. All of these papers are usually based on things that have been published. And obviously, they're slightly different in terms of meta-analysis would look at the statistical analysis that has been done. They would kind of accumulate different studies and then come up with their own conclusions. The systematic review would broaden that a little bit, and it would also involve things that are not really statistically driven. And then we go into prospective studies, and that's what we like to see. Prospective studies are usually less what we call biased. And what that means is that we try to the better, to the best that we can, not to have things that we are under control, so that we can really see how things will turn up. So we can really understand the outcome and study that. Then we have, then in terms of prospective studies, we have randomized trials, and the randomized controlled trials, they are usually ones that, that's when you take the little ticket and you find out if you're going to get the control arm or the treatment arm. A lot of people have a very difficult time with that, obviously, because if you're trying a different treatment and you're handling a child and you have any evidence or anything that makes you believe that that treatment may be better than the alternative, it's always very difficult, you know, ethically speaking and consciously speaking, to start a trial like that. So we do lack those, but in the adult cancer world, those are the best studies because, like I said, we cannot control the outcome. We are learning as we go with our research. Then cohort studies, we are separating a group and we're studying only that group. Case control study is when we have one child, for instance, a sibling that doesn't have retinoblastoma versus one with retinoblastoma, and you're trying to look at maybe diet and exercise and other things and psychological, outcomes. Cross-sectional studies, that's already kind of going into the retrospective studies where you look at just a certain point. For instance, let's look at how all the children that were treated by IV chemotherapy in the 80s, how did they do? How do they look right now? So that's a cross-sectional study. Case reports and series, again, they are also retrospective, and also we feel like that's not the best data we can get, but again, all those things we just talked about. Ideas, editorials, and opinions, it's really heavily driven by the author, and it's their experience, and again, a lot of times you may sense some bias in there. Animal research studies and test tube lab tests or lab studies, this is really something that has yet to be applicable in clinical practice. Sometimes it takes a long time to translate into clinical practice, so again, a little bit more complicated in that regard. So design terminology, things that you're going to hear a lot, people are going to be talking about biases. So biases is anything that can deviate the results in any given way. So for instance, if a doctor is enrolling patients and it's not a randomized trial, they can always pull out the best cases that they think will have the best outcome and say, okay, we're going to use these cases to try this new treatment. So that's definitely a bias because you already have a knowledge of something that may influence the outcome. Causality, or causality. It's a relationship between cause and effect that it produces. Again, it's something that can be influenced by the researcher. And then important terms for you to understand and differentiate is sensitivity and specificity. So sensitivity is kind of what you call the true positives, okay? So how good a test it is to pick up something. Now, specificity is how good is that test at really just narrowing down what you want to find. So those are terms that are very interesting. All of this material you will see in that Dropbox, so if you do get a chance to open on that link, that would be very interesting. So now I want to share with you the history of treatments in retinoblastoma and why we need research so bad. So this is the management trends for unilateral retinoblastomas. As you can see right there, for a long, long time, all we did was enucleation. A child with unilateral retinoblastoma would show up and the eye would be removed. Obviously, in the 1900s, there was still a lot of physicians that didn't do anything and would send the child home, just saying, enjoy your child while they're still around. Then some focal treatments started, and here that's when, the Japanese started looking at some intraarterial and intravitreal injections, not all of them with a good outcome, and then external beam radiation therapy for a single eye, and then in the 1990s, IV chemotherapy took off, and then intraarterial chemotherapy here in the late 2000s, early 2010. And this is how it looks on the bilateral cases, and you would see here that early on, until about the 1950s, a lot of the kids just got enucleation OU in both eyes. So what that meant was that these kids usually did relatively well. but they didn't have vision. They did relatively well in terms of survival. Not saying that the other part, the emotional and the, adaptation into society and all that, that probably was lacking tremendously. But nevertheless, here you see that also for a long, long time, doctors would just completely not do anything and neglect kids early on. And then external beam radiation therapy came along. The worse eye would be enucleated, the better eye would get radiated. And then in the 60s, a great movement started into doing external beam radiation therapy to both eyes. And then finally, again, in the 90s, IV chemotherapy in both eyes. And that's when things really turned around where, we had a shot at preserving the eyes and preserving some vision. So that was really a page turner in terms of the history of retinoblastoma. What are the caveats of these curves? Well, we pulled up this information, Dr. Augsburger, who is my senior partner, and myself, for the International Society of Ocular Oncology meeting in 2013, because we wanted to understand a little bit more. And because we also realized that all these transitions happened without any controlled study. So we found something new, we found that it could work, and we just said, okay, this is the new magic treatment we have. And as much as, like I said, it's very difficult to do a randomized clinical trial when you're looking at kids, we have to come up with a better system. We have to have more rigor in analyzing all this data and all these new treatments, because nothing in medicine is 100%. It's not bulletproof. And although certain treatments are very good, we may find out 5-10 years from now that they're not as good as we initially thought. So all of these curves were done based on the initial recommendation for treatment, not necessarily the treatment. None of these papers included any kids with extraocular extension or invasion of the optic nerve. And more importantly, none of these papers were from outside the United States and Europe and the Western world. So we really don't have any of the advanced cases included there. So interpretation of our findings. First, enucleation is still a principal method of initial treatment for unilateral retinoblastoma in a lot of centers. If the current trend continues though, and we're gonna look here because I'm gonna show you the new trends, intraarterial and IV chemotherapy or a combination will probably eventually replace enucleation as predominant treatment in the 2030s, 2040s. Initial treatment for bilateral retinoblastoma has gone through 4 distinct areas, and that's very important for you all to remember. So first we had bilateral enucleation area, and that's the era that was in the 1900s until the mid-1940s. Then we had external beam therapy from the 1940s to the 1990s. And then we had IV chemotherapy from the 90s to the 2010s. And then now we're in the ophthalmic artery infusion chemotherapy era. And so this is what, based on what we were seeing, that's how we are projecting that this is going to look like in the near future. So we believe that obviously enucleation is going to drop for unilateral tumors, and IV chemotherapy is going to drop as well. And we believe that probably intraarterial and also associated with other treatments such as intravitreal chemotherapy and focal ablative treatments. That's going to be probably the trend going forward. And for the bilateral cases, we believe that we're going to be doing more enucleation / intraarterial and or intraarterial in both eyes, and probably will drop again with the IV chemotherapy and the enucleation IV chemotherapy. Again, it's an estimation. It's based on kind of a trend that we were seeing, but definitely something interesting for you all to consider and you all to understand how this historical development happened. So just showing a couple cases just to make it a little interesting for you guys. So this was a child with a unilateral retinoblastoma that we saw. It was one of our early intraarterial cases. After one treatment with intraarterial, the tumor really regressed very nicely. We were super happy, But after the second treatment, the tumor just exploded almost. Didn't really explode, but it just disintegrated. And there were so many vitreous seeds. And, we spoke with the family and we sort of convinced them to do an enucleation, and the child did really well. The child is now 6 years out from the enucleation, and fortunately, because we decided this relatively early, I think this child really doesn't feel as traumatized with all the EUAs and everything. But I still see her every 6 months, and she's doing tremendous. So another one, this was a child that the family, again, unilateral RB, all of these, and the family did not want the eye enucleated. We had started a trial for topotecan as an intraarterial agent, and you see that there was a very meager response after 7 sessions of intraarterial with topo, and then we said, okay, this is not working well, so we started with melphalan plus here some consolidation treatment with laser, and the child did very well, and she's still around and she's doing fine 4 years out. And finally, this one was a very difficult case that, she had a group B. We did a couple sessions of intraarterial, thought we were done. It recurred. She went back to the intraarterial, and just like that first case, the tumor kind of fell apart. It just disintegrated. It's kind of melted away. And here is after 14 injections, intravitreal injections of melphalan, and simultaneous intraarterial chemotherapy. There you go. So what is the Children's Oncology Group? The Children's Oncology Group is a group that includes pediatric ophthalmologists, not very many ocular oncologists, unfortunately, and other professionals that really look into different cancers, not just retinoblastoma. But they have a very robust network, and they are able to enroll kids throughout the United States and North America. They do mainly clinical translational research, and they do the entire spectrum of tumors, like I said. And they look for molecular bases of disease. They have phase 1 and 3 clinical trials. That means they have very, very basic, still kind of dose trying and everything until they find the safety, etc. They have biomarker discovery, they have survivorship studies, and they have neurobehavioral studies for disease and therapy. So I do encourage you to look at the website, so children'soncologygroup.org, for those that are not familiar. I assume many of you are. I have no financial interest. I'm not actually part of the COG, the Children's Oncology Group. But anyway, I think it gives you some resources, and it also gives you information to discuss treatment with your doctors. And that's the most important part. So there's 9,000 experts worldwide, has nearly 100 active clinical translational trials open. And again, like I said, it includes retinoblastoma, neuroblastoma, and it also includes metastatic retinoblastoma treatments. So take-home message. First, it's very important to understand the different kind of research studies if you ever browse the internet and you want to understand how reliable that data is. It's very important to understand the terminology and how studies are set up and how they are developed. New studies are available in retinoblastoma all the time, and that's where I encourage you to go on the website and look for them and understand what's going on. Treatment of retinoblastoma historically has evolved, and we still have ways to go, definitely. Keep in mind that ocular oncology, or oncology in general, is a multidisciplinary area. And although we are going to interface a lot with the ophthalmologist, you also have the pediatric ophthalmologist, or pediatric oncologist, the neurointerventional radiologist, and other professionals, and then, the social worker, etc., a team. You have to have a good team that you can communicate with. I say communication is number one, and that's really how you take care of your child as a whole and not just the tumor itself, and that's very important. Thank you for your attention.
Can we have Helen's slides up, please, next? Unless there are any burning questions, we'll save everything to the end.
Okay, that was great. Thank you. So my talk is going to be a scientist's perspective on patient involvement in clinical research. Unlike my lovely colleagues who are clinician scientists, I am a scientist alone. So all I do is research. And I started out in molecular research, in the lab, away from patients. Zelia said something really interesting in her first slide. She said that molecular test tube research was at the bottom, and it so rarely translates to the clinic. And I would argue that's because we researchers away from patients can't envision a route to get our research to patients. And also, maybe on the patient side, you don't know how to get to the researchers alone. Yesterday, I sat in the breakout session on data collection with some great clinician scientists and another scientist like me, Ruth Kleinerman, and there were no patients or survivors at the table. And I wonder if we had named the table not data collection, but using your kids' data or something like that, more of you would have been there. But we do have a way forward where we can have patients involved in the research and help us figure out how do we get basic science discoveries together with the clinicians to the patients. So how many of you or your children have been involved in clinical research? Who knows by show of hands? 1, 2, 3, handful. Okay. Just really quickly, how would you describe your role or your child's role in that research? Was it providing a specimen or being enrolled in a study to track treatment progress? Do you know? Anybody want to volunteer? Thomas? Providing a specimen. Okay, yeah, so those are traditional roles, right? So traditionally, patients or survivors are in research studies as study participants. So you're testing a new drug, a new protocol, a new instrument. You might be answering a survey, conducting interviews, or being interviewed, or being in a focus group discussion, or you're providing that biological specimen, blood, tumor tissue, or other, which is all really important. However, perhaps it's limited in scope, and as we heard from Caitlin today, there are new ways of engaging patients in the research process to try to really, the heart of that is to translate more discoveries into real-world application. For me, as a student of genetics, I was really lucky because I worked for a clinician scientist, and as a molecular lab scientist, I could see that route to the patient. I work with someone you might know, her name is Brenda Galley, and she, in the lab, we studied a lot of retinoblastoma specimens, human eyes, as well as mouse eyes and mouse specimens. And one thing we noticed in all our textbooks, a very small thing that reminded us we were working with patients, is all our textbooks showed the retina with the photoreceptor layer, the part of the retina at the top in all the images was what allows you to see, basically. But Brenda would always say, well, that's wrong. You should have it flipped with the ganglion cell layers on top. Yep, there. Because when you look into an eye, that's the layer that's closest to the ophthalmologist looking in the eye. So this is a nice sort of story I like to tell because it reminded us in the lab that even if we were away from the clinic, in this laboratory, doing our crazy experiments, it was all linked back to the patients in the clinic who had retinoblastoma. And so I think the next wave of research, as Caitlin showed us today, is engagement of patients as partners in the research process. Moving from just study participants or research subjects to providing information on research ideas, being co-researchers, telling us how we're going to get those discoveries to you in that real-world setting. And also helping us take those study results and translate them into understandable information for all. We've heard from a number of different survivors here. Some of you have scientific degrees and can really understand the nitty-gritty science of it. Some of you are from different fields and would probably appreciate less jargon-filled descriptions. So we can work together on that. Patient-oriented research really focuses on the care of patients in the healthcare system, and it's really saying more patients need to be involved in the clinical research and knowledge translation process. And so it also has to be research that's valued by the patients. And we heard in the previous session how important quality of life issues are and survivorship issues, and perhaps that needs to be told to even beyond our RB group. Maybe some psychosocial researchers need to be here. Maybe they're not studying retinoblastoma patient or the retinoblastoma experience, but those methodologies from those fields could be applicable to what we want to do. And so there's a number of ways that patients can be engaged, as I mentioned. I'll just speed through because we're a little behind. So I wanted to give some examples of how patients have been engaged in research before. In Kenya, as we mentioned previously in this meeting, there was a national strategy that involved patients, helped inspire research projects, and most importantly, work with clinicians and scientists to develop clinical guidelines of care. And that was similar to a systematic review process, which was at the top of Zelia's slide, where you look at all the published literature and work with a group to see what's the best available evidence to tell us what the appropriate clinical guidelines should be. And those guidelines were published and endorsed by the Ministry of Health because, of course, this research process needed to have also policymakers at the table to really take that research and apply it in the hospitals by having the Ministry of Health endorse it. Another example we've been hearing about is child life. And so child life programs provide the opportunity to learn from patients, the children daily, and how they're feeling and whether or not, how they're experiencing their treatment. Perhaps there's room for research there to really work with even our littlest patients to understand what's important to them. This meeting is a huge example of retinoblastoma research involving patients. It's not research per se, but it's definitely giving me ideas on what maybe I should focus on. The exercise this morning with that little tool was a really nice way to test out something I developed and see, does it work, does it not, where were there errors? Those were real errors. I'd love to say I put them in on purpose, but I did not. So this meeting is a great way to engage each other and really learn from each other and influence research. And of course, the Canadian Retinoblastoma Research Advisory Board that you heard about earlier. So patient-oriented research, I think, is here to stay. It's not just a thing we're doing because there's focus on it and we need to have patients involved in our research to get funded. I really think it's a philosophy of research. It can help facilitate really impactful research that's going to take types of research that were traditionally outside of the patient sphere closer to you. And maybe in our next meeting, we can have researchers here who haven't had that great opportunity to engage with patients and really see what kind of research we can do that's not currently being done. So I have one more thing I wanted to ask, and that was the website, if the AV guy can pull it up. One research project you could help us do, we are currently mapping where retinoblastoma is treated around the world. And there's a website, www.1, as in the digit 1, rbw.org. And basically we have, most of the clinicians in this room have provided information on their data, but maybe on the patient and survivor side, if you go on that map and see that we're missing a pin where your hospital is or where your child has received treatment, maybe you can send us a note and tell us, you know what, you're missing this pin. It's one way to sort of know who we are around the world, where and how retinoblastoma is being treated and with what capacity, but also if there's research being done. Are there clinical trials that maybe might be useful? And it's good for us to communicate with each other as well. Yeah.
One comment, we were actually discussing this map yesterday evening as a way of identifying survivorship centers across the country. But one comment which did come up was that it's not accessible.
Yes, I know. Our lovely developer is here. Amanda Otter, can you put your hand up? We would love any and all suggestions on how to make it accessible. We were working with limited funding. It started as a Google map, and this was a first test. Definitely, we'd like to make it accessible, provide translations as well. So any and all suggestions welcome, and we'll see what we can do. Yes. Great. Maybe we'll go to the next presentation then. Thank you so much.
I just want to thank everybody for being here, and especially Jesse. Thank you for the invitation. It's my first time at this meeting, and I really like the group that's here, and I like the spirit of this meeting. It's very different from the ones I usually go to. So I have the joyous task of talking about some of the successes that we've seen in our field and how children have played into the research that we've done in retinoblastoma. So we have made a lot of advances in retinoblastoma, particularly in recent years, and this is because of the wonderful collaborations between researchers and clinicians, but largely in part because of the contributions that patients and families like yourselves have made. I think that not a day goes by when I don't learn something from a patient. So true, I've finished my formal training, but I'm also recognizing that I'm a learner. Every day I learn something new, and I think I wouldn't enjoy my job if I didn't. So none of this is really possible without research, and I just want to show you some of those stories. And first, before I say anything more, I want to say that in medical research, especially research that involves children, there are very robust safeguards in place. Children in particular are a vulnerable population, so no idea for a study starts unless it's very intensely reviewed by an institutional review board. There are ethical committees, there are safety monitoring committees, and there are very strict regulations for informed consent. I think in 2017, we're doing pretty well. Retinoblastoma is a challenging disease, but when we look back 100 years ago, we've made significant progress. We have, in most cases, we have excellent survival today compared to 100 years ago, where we really didn't. We have fewer eyes being removed, and many times we can save vision. If you look back to the early and mid part of the past century, radiation was the mainstay of treatment. And it took many, many years to realize that while we were saving lives, that this was disfiguring, and even more concerning, there was an increased risk of secondary malignancies, particularly in the field of that radiation. So today we're very fortunate. We have many, many therapies that are available to us. We have many different types of chemotherapy. And in the current era, chemotherapy really predominates. So we have intravenous or systemic chemotherapy, we have intra-arterial chemotherapy, and intravitreal chemotherapy has very specific indications, but we have that form too. So I want to tell you the story of systemic chemotherapy. This evolved in London in the early 1990s. That's like yesterday, I feel like. And this was a collaboration between clinicians, ophthalmologists, radiation oncologists, but really I want to highlight the role of a pediatric oncologist. It really wasn't an ophthalmologist or an ocular oncologist that developed chemotherapy for retinoblastoma. It was a pediatric oncologist by the name of Judith Kingston. She passed away unexpectedly last year, and she was a keynote speaker at the International Society of Ocular Oncology in Paris, and many of us were there. She got a standing ovation for that talk, and that just rarely happens in a scientific meeting. It was really very, very moving. So, but realize before systemic chemotherapy could be used in the mainstream setting that there were many, many parts of it that had to be worked out. What were the medicines that were going to be used? What doses should be used? What interval between the cycles? And how many cycles should we give? So all of that came about through research and wouldn't have been possible without our patients. This is a little boy from Mongolia. Until recently, I worked at Johns Hopkins. We had a very robust international office, and I started seeing children from Mongolia where there's no treatment available for retinoblastoma. And this little boy did fantastic with systemic chemotherapy and has 20/20 vision, even though he had multiple tumors in this eye. Intra-arterial chemotherapy, please realize that this is not something that the ophthalmologist gives. This is done by a very highly specialized team. It never would have been possible until specialties in medicine like interventional neuroradiology came about. So we've only been able to do this in recent years. You can, as you know, a catheter is fed through the femoral artery, and it can be advanced north into the blood vessels in the head until it's gone into the ophthalmic artery, and then the chemotherapy is delivered directly into the artery that feeds the eye. And we also have excellent results with this form of chemotherapy. So this is a little girl. She had bilateral retinoblastoma. She was treated with 3 cycles of intra-arterial chemotherapy, and at last follow-up, she had some vision in both eyes, and she still has both eyes. But again, realize that this technique never would have been possible without research and helping to figure out what medicines to use, which combinations of agents to use. the doses and the delivery technique. And even the techniques evolved, so we learned to inject very, very slowly. And none of this would have been possible without research and without patients contributing to those studies. In intravitreal chemotherapy, we use that specifically when there's residual vitreous seeds. It's highly localized, and we're able to save even more eyes and vision because we have this technique now. This is an 18-month-old girl. She had unilateral retinoblastoma. She had 3 cycles of intraarterial chemotherapy, but she had residual vitreous seeds and they weren't going away. And so with injections of intravitreal chemotherapy, just a couple, she had very nice resolution of those, and she still has her eye, and she has some vision in this eye too. Again, we had to decide which medicines to use, the doses, the frequency, and the technique is highly specialized. This is not like injecting any other medication in the eye like we do for diabetes or for macular degeneration. These are highly specialized techniques, and they had to be developed over time and with a lot of help. So in summary, I think we've made tremendous strides in this field. It's been a very collaborative effort. None of this couldn't have been done without the relationships between the medical profession and the patients, and there's a lot of exciting avenues coming down the road that Dr. Berry is going to talk about. I love this picture. This is one of my patients, and it just tells the story that it is not a child, but there's a family. It affects everyone in the community. It takes a community. This is the child's mother's, she was a teacher, and these are all her fellow teachers wearing the jersey, and I just love that she shared that with me. Thank you.
Can I have the implant slides up? So I'm going to try to be really quick so that I leave some time for questions and some time also for the physicians from other centers to talk about research innovations from where they treat. But I'm going to tell you guys 2 from CHLA. This was actually at the request of a patient. So I'm going to just briefly talk to you guys about a study that should be opening in January at our center. So Lynn Murphy, as I think many of you in the room know, started the CHLA service, the CHLA Retinoblastoma service, and he has done wonderful things for retinoblastoma patients. And one of the things that he developed was a localized mechanism for developing chemotherapy. It's called an episcleral reservoir. It is a small piece of plastic. Does this have a pointer? Right here, which allows drug to pass through only on one side. So not the top side, but on the bottom side, which is attached to the sclera, which is the white part of the eye. It is about the size of a ladybug, so it looks a little big. It actually, I think in this drawing, looks bigger than it is, but it's about the size of a ladybug. It sequesters the drug in this plastic, and it allows it to diffuse across the sclera, and then the concentration of the drug has been measured in the vitreous cavity. So our plan, starting in January, it will start at CHLA, and the plan is to very quickly open at St. Jude's as well as Houston Children's, is to take eyes that have secondary tumors that otherwise would be enucleated if we offered them no other therapy. I will get to this. You all are right about this. Place the episcleral reservoir on the eye. You place it in the area where the highest volume of tumor is present. It'll stay on the eye for 2 weeks, and we will follow the response. So we're really excited about this. The drug that we're using is carboplatin. This has been in the works for, I don't know, before me. Topotecan, sorry. It's Topo. How long has this been in the works? 10 years? I mean, it's really been in the works since before I started treating retinoblastoma, which just goes to show 15. It goes, I won't tell you how old I was when I was 15 years ago, but I wasn't treating RB. Just goes to show you guys how long it takes to get these initiatives into the patient population. But we're very excited about that. This is not, there's one last slide I want to show, if it'll come. There it is. So this is the last slide I want to show you, which is actually, this is how the drug reservoir will come. Again, this is a very small, tiny piece of plastic. You can suture this to the eye, but I think most people will actually use a small amount of glue to hold it into place in the sclera. It'll be placed at examination under anesthesia. If you were doing this for an adult, honestly, you could place it in the clinic. It's just a very small, small incision to place this. But of course, for kids, we'll place it under anesthesia. So we're really excited about that, excited that all of Lynn's efforts are finally coming to fruition. And I hope I've answered the questions that whoever requested this had about it, but we will talk about it more if not. And then the last thing that I wanted to show you guys, I actually had slides on, but the paper is coming out tomorrow. And so USC made a media release, which is intended to explain the research to people who are not scientists studying chromosomes. So I thought it would be best to just show that. So we'll show the media release, if you can pull the video. It's under embargo until tomorrow, so I'm not technically supposed to be showing this to you guys, but it's fine.
As a retinoblastoma surgeon, that was always really frustrating to me is that two kids would come in and they would look exactly alike. Same age, same size tumor, same eye affected. I mean, these two kids looked exactly alike. And you treat them the same way, give them chemotherapy, and one kid would respond, and one kid wouldn't. And I just knew, it wasn't just me, we all knew that just like breast cancer and prostate cancer and lung cancer, there had to be some sort of genetic etiology for why one tumor responds to treatment and the other just is so aggressive and recurs and recurs and recurs. But the problem with retinoblastoma, unlike breast and lung and prostate cancer, is you can't just go get a piece of tumor and check for those genetic changes. The only time you actually get access to tumor tissue is when you remove the eye. And so, yes, sometimes we have to remove eyes in retinoblastoma, but obviously we don't want to remove it just for tumor tissue. And obviously, once the eye is removed, you can no longer correlate things. So you can't say, like, okay, these are the genetic changes. Did the cancer respond to X or Y treatment? We've been doing an innovative new thing. So instead of taking a tumor, we've been able to take clear fluid in the front of the eye. It's called aqueous humor. And we searched to see if there's tumor DNA in the aqueous, with fingers crossed, and there is. So for the first time ever, in eyes that are being treated and eyes that have not been removed, we now have access to tumor DNA. We've analyzed 50 samples so far, actually, and our first publication is coming out, which is just the first few. But already in the first 50 samples, there actually is a difference in the genetic profiles for the tumors that do well and the tumors that don't. I could not have done this research without the collaboration that exists between USC and CHLA. I'm really hopeful that in the future, the aqueous will open up an entirely new era of precision medicine for these retinoblastoma patients. You're going to have to ask me in 5 years, but I really do hope I can say game changer. Not I hope it's a game changer, it was a game changer.
So we're super excited about this. Again, the paper that's coming out on Thursday really just shows that that fluid, which is the clear fluid in the front of the eye called the aqueous, it's not next to the tumor, it's in a different compartment of the eye entirely, but there is tumor DNA. And so again, for the first time, this allows us to find tumor DNA in eyes that are being treated, and it allows clinical correlations. And we are halfway through paper 2, which is more exciting than the first because, again, there is a difference in the tumors that responded and the tumors that didn't and needed secondary enucleation. And so I have a lot left to prove, like I said in there, but I'm very hopeful about what this research will provide for other patients. And I could not have done it without patients. There's a mom of a patient in the room that's in the first 50 samples. So it was really important, really impactful, and you didn't need to see all the CHLA and USC stuff, but it took an army. So let's open it up to questions. Yeah.
After you remove the liquid, how long does it take before you can figure out, the results and how you're going to act?
Sure, that's a great question. So if this were to be done in the clinical setting, it would need to be done quickly. And there are even handheld sequencers that are available now. So it could be done clinically. In a research setting, to run an entire genome to look for chromosomal changes takes a big machine and is expensive. And so you wait until you have a certain number of samples, generally from multiple research studies, and you run them together. So in the future, it's something that hopefully we'll be doing fast. In the research setting, it's not done fast. It takes about 6 to 8 weeks. Yeah.
Thanks. This is very exciting. My comment was for Beth. And I just wanted to recognize someone who's not in the room and who is retired, I think, and doesn't do retinoblastoma anymore. But I was a fellow before 1990, and Helen Chan, along with Brenda Galley, we were actually doing chemotherapy for retinoblastoma. I know because I've got the pictures and I've got the patients. And so I think, again, for this, a big army of people kind of made it happen. But Helen was a bit of a pioneer and a rebel and really sort of blazed the way for us. And I think that's the story for retinoblastoma. All these things are cumulative.
Yeah, and thank you for that. You realize anytime I recognize someone, there's someone I should have recognized, and thank you.
We have someone from the news feed, maybe? Live feed?
So we have this question from someone you know, Abby, in the UK.
Hey, Abby.
So I'm going to read it verbatim as best as I can here with my screen reader. So, no one so far has noted that survivorship is going down currently with the increasing use of IAC. While she agrees that it clearly has a place in the care of children with RB, the collective research has yet identified for which children it's safe or effective. Meta-analysis and a collective research is made possible due to the poor quality of the study done to date. Doctors say that the rate of death is no greater from IAC or from the intravenous chemo. However, many children are receiving AIC who would have previously had a nucleation. So she expects that it's why we're seeing increasing numbers of children relapsing and dying. She wants someone to please comment on this.
Brenda, do you want to comment on that? I mean, your study was probably one of the best, meta-analysis.
Well, it wasn't a meta-analysis because that was not possible because of the quality of the data in all the papers around IAC, where you could not track one child from beginning to end through any paper. They're multiply reported, the same child's in multiple papers, but you have no idea which paper they're in. And there's no trial. So Abby's asking very important questions. And many of those papers say there are no deaths, but we know of deaths of children primarily treated and sometimes extensively treated with intraarterial chemotherapy. Some of them are lost to follow-up because they went home to Bangladesh before they died, et cetera. So this is a major problem of the retinoblastoma literature. And I'll just expand that to Mary Beth. You commented on these treatments as if there was in a research environment here now in this session, as if there's research on them.
Yeah, but there isn't.
The major treatments to try to save eyes has been radiation, external beam radiation, over a very long period of time, and then intraarterial chemotherapy, and then you pointed to intravitreal chemotherapy. Intravitreal chemotherapy has a very precise use
application
and very well defined and very unlikely to kill children. The other two, we know about radiation. We know how bad that was. Why did it take so long to figure it out? Because there was no clinical trial. There was no place where every child who was irradiated was then counted for and followed for a whole life of survival. Mm-hmm. If it had been in that format, if it had been a research trial, external beam radiation would have been stopped much, much, much earlier. But now we're in the middle of intraarterial chemotherapy. And that, again, has started like the radiation, the external beam radiation. Every child should have it. The same words are in the first papers for radiation and in the first papers for intraarterial. No child needs to lose an eye from intraarterial chemo, from evermore for retinoblastoma. We don't need to take out any eyes. We can save every one with intraarterial chemo. That is absolutely false. And so I think the external beam radiation, at least was published in the literature. The intraarterial chemotherapy, the first paper, was in the New York Times. That's a little bit like marketing. It's not research. So we badly need, and this group is the place to demand research that properly evaluates new therapies and to back off intraarterial chemotherapy and say, what is the true data? We tried to find that from the published literature, which is vast. But how many patients are there? We have no clue, because you can't add it all up. You can't add up how many are dead, because you know of ones that were treated that died and aren't in the paper. So it's a mess. So how are we going to fix this? Mary Beth, what should we do for good clinical research?
That's true. We need higher quality, good, prospective, randomized studies for retinoblastoma. No question.
There is an open intraarterial trial for them in the COG, Unilateral Group D. It's having some difficulty, is my understanding, but it's open.
I'm not sure that that will ever succeed in this current environment.
Yeah.
You might find a place where you could randomize between what? You're not, intraarterial and systemic chemotherapy would be the correct randomization for a unilateral D at presentation.
Yeah.
I think that would be a great trial. I don't think it's going to succeed as it's designed, and a randomization is going to be very, very difficult.
Yeah, I think you're right. Randomization, particularly in this setting, is extremely difficult.
There's many reasons to not randomize in retinoblastoma because of the complexity of two eyes, of all of the many, many reasons that are very valid reasons. I think perhaps China is the best place to do this, and maybe with Bhavna leading a really coordinated Indian center where there's enough patients, Bhavna succeeded in a much more straightforward randomized study, and that succeeded because it was in the world of oncology, not ophthalmology. I'm sorry to bash ophthalmology, but we haven't done a good job. So that would be the place to do it where there are enough numbers. I think in the US, if you put every eligible eye on it, you still wouldn't get enough numbers to randomize correctly in a COG study.
That was exactly my point when I showed you guys all that historical evolvement. It's because we have evolved to a certain extent. However, we don't have the data to say if our evolution is exactly the best one. And one of the things that we moved away from radiation, and as Brenda knows and other people here in the room, at the time of radiation, yeah, we did have a lot of problems. It wasn't the best answer, but we didn't used to see as many relapses as we're seeing in the era of IV chemotherapy or intraarterial. So it wasn't good. There was a lot of problems. However, we didn't see teenagers with relapse or adults with relapse, and we're seeing that with chemotherapy. So we gotta figure out what's the best way. Does every kid need consolidation treatment? I don't know what's your experience, Brenda, with that, but I think that that's something that needs to be brought up as well. What do you do? Chemotherapy alone, what about 10 years down the road? What are we seeing then? And I agree with you. Nobody is reporting the real bad cases.
I don't think IV chemotherapy or intraarterial chemotherapy alone work. Alone.
I agree.
And nobody's ever said that, although the oncologists in some parts of the world have thought,
yes,
oh, we can treat with chemotherapy. We don't need an ophthalmologist to even look in the eye. That's, of course, not true. Mm-hmm. You need multiple treatments, and you need to pay a lot of attention to following them up. But I do think that the systemic chemotherapy has done a very good job with the majority of eyes, but I haven't got data to prove how it compares to intraarterial, that's for sure, and how many other treatments do they need. I think the intravitreal chemotherapy has been a landmark because it lets you get at those very, very difficult seeds so that they're not an issue anymore. We don't care about seeds anymore because they respond so well to intravitreal melphalan, not to other drugs, but melphalan's really pretty good. And that is that hasn't also had a clinical trial.
Exactly.
But as I said, it's not so dangerous.
Yeah, no.
And it doesn't risk life in the same way. Although they were worried about it risking life because you put a needle in an eye with live tumor in it, but doing it very carefully and precaution and the melphalan, it's safe.
Shown to be safe.
So I think that we need to approach everything we do with. Maybe if we can't do randomized trials in retinoblastoma, at least we can report it correctly, where every child is documented and every single treatment that combined resulted in success or failure is in the paper. And we haven't achieved that yet across the board in retinoblastoma research.
I agree entirely.
Agreed.
Very well put.
Yes?
Thank you. I'm very concerned because, the more awareness I do in my country, I start facing challenges that we used not to face. Like, for example, I have an ophthalmologist who is dedicated to my children who have bilateral retinoblastoma that have been already treated, one eye enucleated, the other eye with vision, and trying to be controlling the new tumors that are starting in the other eye. So I find myself facing this situation that my ophthalmologist, he has laser, he's doing focal treatment, but then he finds more challenges. And then I said, okay, he's going to need more training on vitreal, the intravitreal treatment. He hasn't done that. I mean, in our settings, you talk about things that, for me, are novel things. You know what I mean? In Honduras, because my ophthalmologists were not using this like a routine treatment because this is a rare disease, and we are having, at this moment so far, I have 3 children in that situation that they are going to need vitreal treatment. And then I saw this novel thing that you are working with, and that with a small size of a ladybug to put in the eye. So I start asking, where can I send my kids to put that? You know what I mean? And we are going to start needing all these things in limited resources countries. And then I'm going to knock on the doors of the people from developed countries who are going to say maybe, I don't know, they might not say, yes, I'm going to help you. You know what I mean? We have had the support and the help and the twinning with St. Jude. And I heard that you said that now you are going to work with that because, for example, my 3 children were already treated with chemo, and they have been treated with laser, and now what else? They have new lesions, and they have vision. And they are 3 little kids, beautiful, playful, and everything. I wish I could brought them here, but we don't have that money to bring them with their families. So, I don't know. I think that God brought me here to see you and talk with you and see if there are open doors for my kids.
Well, I think 2 things. Multiple studies have shown that group D eyes, these advanced eyes with systemic chemo, cryo and laser alone, are 50-50, right? The SHIELD study, our study, Galley study, multiple studies, it's about 47 to 50% success. So half these eyes are going to recur, and the recurrence for the majority of cases is from seeding. Intravitreal injections for an ophthalmologist is something that most people are trained in doing, and they're done all the time. Now, the way these are done is different, right? It opened the door to my research because you need to lower the pressure in the eye by taking some aqueous out beforehand, and then after you put the needle into the pars plana injection site, you freeze that area as you pull the needle through. That being said, I don't want to speak for other ophthalmologists in the room, but I would say most ophthalmologists, no matter where they are, that's not a very technically difficult procedure, and melphalan is relatively cheap, actually. I mean, it depends, but it's much cheaper than intra-arterial, for example. So that's a great option. I have no idea. I don't think anyone knows, and even if Lynn were here himself, I don't think he would be able to say when or how the implant will get outside of the US, but that was actually always his intention. His intention when the whole intra-arterial when that took off, he said in developing countries, this is too technical, it's never gonna work in a functional way for these kids, but it's easy to do a small little snip in the conch and put this reservoir in place. So I think we're getting there. I'm very grateful to Munier though. I think the intravitreal melphalan is a really wonderful treatment. And again, most ophthalmologists know how to do intravitreal injections and can add the small steps needed to make it safe for retinoblastoma patients.
I would just I know we're going to get to it, but if you are in Honduras, I would suggest to you there's an excellent center. There's actually 2 very good centers for retinoblastoma in Mexico. And if you're thinking about streamlined treatment, especially in Mexico City, there's a very, very good group there. And I'd be happy to help you with, getting contact information and everything. I think that would be more friendly in terms of the language, and I'm sure cost-wise too, it would make more sense to you.
Can I also say one thing about that? Because I think what I'm also hearing, and maybe is relevant to our research panel, is in how we evaluate the best medical evidence. Because what I'm hearing you say, Ligia, is that medical treatment and our evidence is moving towards methods that maybe aren't yet feasible, or there's not as much capacity in Honduras at the moment. And maybe there's also some factors we haven't considered as to what are the patient needs, you know? And I think that will differ depending on whether you're talking about a high income setting or a low income setting. And the answer is not always going to be contained from a purely medical side. Maybe there are other types of factors, socioeconomic, that go into medical decision making. I'm not sure. I think we need to do more research to figure this out. Sameh did an interesting paper from Egypt looking at maybe social reasons for enucleation. I think it's a little more complex than just medical capacity. I know that's weird for me to say, given I just showed a map mainly talking about health services. So from this, I think, just to bring it back to my presentation, we hear from the patients in the different settings to hear what do they want, you know?
What do they need?
Yeah.
Kate?
I would just like to make sure that we don't leave people with the wrong idea. In developed places, saying that you have an OCT or a UBM or anything else in the operating room to clear the pars plana before you stick a needle in it is simple. That if she doesn't have an ophthalmologist who's doing this regularly, she probably doesn't have a UBM, and you don't want to just be putting a needle in the eye, so please don't oversimplify it. There are safeguards, and you shouldn't be undertaking them without it, and that already just ups the ante. No UBM machine, nobody else to operate it, so it's not trivial. It's not just a matter of putting a needle in the eye.
Yeah. So that goes to my point of evaluating the evidence based on context.
I agree with you.
I'm sorry to insist on this, but it's just that, you see, this is so much complex, you know. We are physicians, we are oncologists here, we are ophthalmologists here, we are parents here also. And what we have seen in a different perspective, you know, for example, like explaining, if I talk with the parents of these 3 children, they are going to say, the moment that my son has vision, I would like to save his eye. You know what I mean? You are in a limited resources country, maybe in a developed country, there you might have more support being a person without vision. You know what I mean? And more accepted, comparing to the other psychosocial and economical situations in limited resources countries. But it's true, at the moment that we sit with the children, with the family, and we are going to ask which are their expectations, what they would like to do. Mm-hmm. At the moment that I said, locally, my ophthalmologist is not able to help you to solve this, what might happen is that these people are going to take all the journey to go to a developed country. And you will find him knocking at your door in an emergency room in a developed country. That might be, you know, what a family can do, seeking for the health and the best quality of attention for their kids. Mm-hmm. And that's the situation. It's just that I was thinking that maybe, like during the meetings for ophthalmology, there could be an open opportunity for ophthalmologists of limited resources countries to get that kind of training, you know, and to get interest on that. Because there is another situation that if something doesn't bring profit, sometimes people don't look for it. You know what I mean? Like, especially talking about physicians. I'm sorry about that. I'm also a physician. But sometimes it happens, the private practice against the public practice. It's very sad. Thank you.
Sorry, I'd just like to first congratulate Lynn Murphy's, what is it called now?
We're still calling it the episcleral reservoir.
Okay.
I know.
We had a much better name, but that's all right. The reservoir.
That's what they're doing, the reservoir.
Okay. So that has, because it's in a formal process for approval as a product,
Yes.
that means it's going to get proper clinical trial, which is what you're going to do locally and start in January. So the data will be looked at, its use will be carefully documented, and it won't get its complete FDA approval to sell it until you've got high quality data. So that's
Correct.
really exciting. The other things like intraarterial didn't have to get FDA approval, so we just did it all, you know.
Correct.
But I think it has a very exciting role potentially for places like the Honduras and maybe addressing some of those problems. But you also said something about the desperate parent to save an eye. But are they saving it for vision or because it's an eye? So I think it's up to the whole medical team and the whole team around those patients to not give false hope. Just because you can maybe make attempts to save an eye with no prospective vision, that's also the dangerous eye. That's the truth. And false hope to keep thinking you might get vision in useless eyes is really, really dangerous. It's much better to take it out.
Agreed. In Los Angeles, it is not infrequent for children from other countries to show up in LA and come directly to the CHLA emergency room. And we have not been able to treat a single one of them. They were all enucleated. So, because that's what they needed. That's what they needed.
And also, Abby had a very nice poster, I think, at the last 1RB World meeting, where she looked at the financial cost of patients flying around the world. And that's a risk we need to be telling our families. You're risking the well-being of your whole family by making these expenses to go across the world to try to save an eye that maybe won't happen. So what's our responsibility to really look at that? And that's related also to Abby's question about how many children are dying from IAC. Obviously, our literature is not telling us. As a researcher, I can't look at the literature and know and do a study on this, but we're hearing it anecdotally. So how can we work together with the patients who have this information and once and for all see what is actually happening? And that also goes for all these social side effects of seeking treatment across the world. And I think the medical community and research community has a responsibility to the patients to look at those kind of social factors and social risks related with retinoblastoma. It's not just the risk of the tumor in the eye. And we don't want, as the medical and research community, to make it worse.
Yeah, and it's a very delicate balance because pushing treatment forward can put a child's life at risk. So some of your gains come with huge losses. Yes. Thomas?
Thank you.
No,
Thank
it's
you.
okay, sorry.
Well, in case you thought Abby was not here, from Abby once more. Care in developing countries for sight-saving care follow-up is so important. She says that she sees far too many children who have excellent eye care from, I'm sorry, my screen reader. She says that she sees far too many children who have excellent outcome from eye-saving therapy relapse and die because no one is following them up. Yes. And she's the one who has to pick up the pieces via the internet, which is absolutely emotionally exhausting.
And that's precisely the things that don't make it into our papers. Because when we're done in our high-tech centers with that was a good visual outcome, now you go back to your country, we don't know how to report on that. That goes somewhere it's not being reported except on social media.
That's right.
I had a question just in regards to Dr. Galley's sort of the portal for all the information. And I'm a retinoblastoma parent, but we actually moved and we had to go to a different center. And, we actually use the internet to map the tumor and, email it back and forth. And I'm just wondering, with all this great, virtual things, is there any way to do sort of everybody collaborate and talk about their tumors and maybe do telehealth to all collaborate together to get these studies? I mean, it would probably really exhaust the doctors, though, with the time zones. But it really helped me because I didn't want to leave Los Angeles, but financially we had to because my husband's job was in Seattle. So, luckily we were able to do that, and I felt safe because I had the internet.
I think there are examples of that. In Canada, certainly, once a month, all the centers log on at a time when it makes sense for every time zone and discuss current cases. I think Cure for Kids is a platform of St. Jude's where maybe it's not telehealth, but they do share cases. So there are examples for retinoblastoma case sharing, I think, but I'm just a researcher, so.
I think the most challenging thing, at least in my experience, every patient I see, I send out communication and letters to every single doctor that is involved in this child's care, or an adult for that matter, because I do ocular tumors, so I see both kids and adults. So I make sure everybody knows what's going on. But the opposite never happens. So if I ever refer an adult or a child back to the community doctor, or if they move, I never ever hear back again from whoever's taking care of that patient. So I think that, one of the things that is important for all of us physicians is to realize that communication goes both ways. And it's not just who receives the patients in the beginning, but also going forward. So every once in a while, I kind of stop and I go over my list of patients and I'm calling their homes. And I'm like, hey, this doctor such and such, and I'm just checking in, just seeing how you're doing. Oh, you're doing great, awesome. When was the last time you were, in to see your doctor? Oh, that time. So I'm here and I'm writing down my follow-up, in my own little chart, because I am interested in knowing what the patient outcome is. But obviously, if the patient goes back to another country and everything, how are you going to track them down? So I think that it starts with the families, with the doctors, and the families asking. And I tell my patients, I say, when you go back, make sure you ask your doctor, are you communicating back with the doctors in Cincinnati? Because that's the only way to make sure that happens.
Yes.
Sorry. So I'm terrified to ask this question, but I need to. So I have a unique case in which my son was diagnosed and presented as unilateral. He was enucleated at that time, which I'm so thankful for because it probably saved his life. And then later developed tumors in the other eye, and he had IAC, which probably saved his vision, or at least up until this point. So obviously there's some controversy about both the research and the procedure, and going forward thinking, how do we interpret research that may or may not be clinically sound? And how do we know, if there's going to be a high rate of relapse in these cases, which you never know, you just go. But if there is, then moving forward, then how do you know how to proceed in a case like that? Especially like my child is already missing an eye. He does have vision. IAC has preserved that to this point. But then if he relapses, then where do I go? Or how do we protect ourselves in looking for literature that is sound? Because there are many papers written on IAC, and how do you know, like you said, when there's been repeat kids and you haven't followed one from start to finish, all those things, how can we protect ourselves to make sure that the literature we're finding is accurate?
Well, Dr. Galley gets to the microphone. I'll get started, Brenda. So I think the thing that you have to look for is some buzzwords. Is it a prospective study? Anytime you have a retrospective study, obviously you, for the most part, have asked the Institutional Review Board or the Ethics Committee for a waiver to report unidentified information. So a retrospective study is never the same quality of evidence as a prospective study. A prospective study is less likely to have bias. Now, the important thing, I think, in relationship to oncology and tumors is that any study that has less than 5 years of follow-up, and for children, probably less than 10, you really don't know exactly what you're up against. And that's somewhat what happened to external beam radiation therapy. I mean, it was great, it controlled the tumors and everything, but it wasn't until 15, 20 years later that we started seeing soft tissue sarcomas and other things in the field of radiation. So I think that, the interval to follow up, it really depends on what population. Now, if you're looking at adult patients, they're going to have another 15, 20 years to live. Even if we end up having problems in the end, well, they're going to be like 90 or 95, that's okay, but they're not going to be young adults. So now I'll let Dr. Galli pick up from that one.
Well, I think it's very difficult. I don't think patients can expect to be able to go and find the answer from the researcher when a lot of minds trying to pour through it and find an answer, find it's not there. So there is no good data existing on IAC and its effectiveness. However, I think IAC has a good role because you can tell that it does do some things. It won't do the whole job, but you talk about recurrence. If the eye's being properly followed regularly, when you've got scars, you're using optical coherence tomography to say is it a scar or is it a tumor, and you're using focal therapy to patch up all the little things and keep watching. That's a very good, successful way to go. And time has a lot to do with it in retinoblastoma. If there's been no more, the tumor cells don't sit there able to grow for 10 years, unlike in melanoma and other kinds of cancer. So it's quite a clear path. But I'd like to just change the angle of approach to the same problem for a moment and challenge We See Hope, and USA can lead that, perhaps, moving forward, and challenge Abby, who's busy doing many things. But why don't we help the families and parents and make little committees around issues like IEC or intravitreal or any new thing, and provide a document like the systematic analysis, but written for real ordinary people to read and understand, and point to the problems of the literature, the best possible scenario that could come out, and a committee of 50% parents and 50% medical or scientists and others who aren't parents or survivors. That would be a really exciting initiative, and we could start with one area and work it forward. So that I would put forward as a looking forward concept, moving to maybe the next section of this meeting.
Perfect transition. Unless you guys have any more burning research questions, I think we are going to skip the breakouts so that we get you guys all to your flights and trains and whatnot tonight. And Helen and I are going to close down the session with cooperation from you all to discuss looking forward and goals that we as a broader RB community would like to pledge ourselves to until the next meeting.
Yeah. So maybe what we could do is just gather your thoughts. Yesterday we had some really nice discussions. We're going to skip the actual breakout session just because of time. But we can use the last few minutes of this meeting to discuss as a group what we think could be really good actions going forward. In terms of research, including creating survivorship care plans. Do I have a program? Maybe.
Yeah, I actually would like a program too. Marissa, can I have a program?
This is just today. Yes, it's today.
It's just today, sorry.
Thank you. Okay.
It won't be too long.